Thank you very much. Let's start without wasting the time of our topic. It's a very important topic. I think this initiation is very high. We all discuss in our local meetings and in case discussion that we have to come across a very younger population, especially in our emergency. And sometime we astonished to see कि अल्लाह ने हमें जो उम्र दी हुई है शायद ये सारी बोनस के अंदर ही है कि इतने यंग लोगों को एमआई और फिर कॉम्प्लिकेटेड एमआई के साथ वो प्रेजेंट करते हैं या जिनकी इंटरवेंशन हम कर सकते हैं. तो ये अलार्मिंग सिचुएशन है बहुत ज़्यादा फॉर आवर सिचुएशन, आवर पॉपुलेशन एंड स्पेशली जो वी आर प्रोवाइडिंग द सर्विसेज. तो चूंकि हम फ्रंट लाइन पे हैं इसलिए हम ये देखते हैं कि ये बहुत यंग एज के अंदर 20s के अंदर 30s के अंदर 40s के अंदर जो वेस्ट में they think it is not usual to have a MI before 45, before 50, before 60. Rather, this is very much usual in our setting that we are having the middle age and the younger age population greater as compared to the population above 50 or above 60 with acute MI, with complication of MI in our emergencies. So it's a very important topic, good initiation. We started with that. And if we go straight forward to the introduction, the coronary artery disease is the leading cause of death in throughout our leading cause of death in the West. Acute myocardial infarction among young is relatively uncommon. It was considered before, but now the data is coming up from last 10 years. They have studied and seen that every year there is 2% increase in the presentation of young people below 45 or below 40 of age for acute MI in our emergencies. Initially, it was considered that cutoff age is 45, been used in most studies to define the young patients. And now the studies are coming up that they are using the cutting age less than 40 also for the, and a lot of cases they are reporting with young in 20s and 30s for acute myocardial infarction. So if we see the prevalence in younger age, less than 40 represent a relatively small portion. Although if we compare with total population in the West, they're 3 to 10%. But every year there is a 2% rise. That means the numbers are building up, and now more and more people, they are coming with younger age and acute MI or complication with ischemic heart disease. The actual prevalence of the disease was found 0.5% in men and 0.18% in women between 35 to 45, and 20% in men and 17% in women over the age of 60 years. The coronary artery disease in young population age less than 40 was found to represent only 3% in all patients with ischemic heart disease. And if we go through the causes of MI in young patients, and we can roughly divide into two categories, those with angiographically normal coronary arteries and those with the coronary artery disease. Some young patients have normal coronary artery disease, but MI in them can be caused by arteritis, thrombosis, or embolism, or the spasm. And in the case of venous thrombosis, coronary thrombosis can be seen in hypercoagulable state, such as protein C and protein S deficiencies and antiphospholipid syndrome or in nephrotic syndromes. These are few various reasons which can initiate the coronary thrombosis, as with the thrombosis of any part of the body also. So the plaque rupture still remains the most common etiology of myocardial infarction, but unique syndromes such as the plaque erosions, coronary microvascular dysfunction, spontaneous coronary artery dissections, and coronary spasm related to drug use are more prevalent in this age group also. So if we divide, we can group these patients into 5 categories. MI is related to the traditional cardiovascular risk factors similar to those in older individuals like hypercholesteremia and hyperlipidemia and dyslipidemia, and use of recreational drugs which are more common in this age younger group, especially in the West, and now it's becoming fashion in our part of the world also. The use of cocaine, amphetamine, marijuana, and or newer drugs, they are coming up with the various cardiac complications also. And MI due to the spontaneous coronary artery dissection, this is also very known entity which is we usually come across in our practice also. Younger females, mostly they are more prone to have these coronary artery dissections. Myocarditis, recent the COVID-19 era, now we are facing myocarditis and coronary artery disease also presenting like MI in patient with the COVID-19 also. And of course, the coronary embolism and spasm. MI due to coronary artery disease, but without critical coronary artery stenosis. This is also a one entity in which there is a positive remodeling, minor plaque that gets ruptures, and angiographically it seems that the patient is having a normal coronary artery disease, but there must be, if we see through Abbas or through other imaging modalities, we will come to know that there is a minor plaque which gets ruptured and the clot form on that plaque. Geographically, it looks minor disease or normal vessel, but there is definitely atherosclerotic plaque in that. And of course, the coronary vasospasm is another cause of that. MI related to traditional cardiovascular risk factors in patients with atherosclerotic coronary artery disease. Plaque rupture accounts for approximately 60 to 65% of the cases. MI in young individual and similar to older individual, and this is most common cause of MI in this age group. Basically, the dyslipidemia, which is more prevalent in our part of the world, that is high triglyceride levels and low HDL, and that is diabetic dyslipidemia type of things which are more common in our population. We usually see that most of our patients, they are having normal or near normal LDL level, but their triglycerides are high, and mostly I have never seen yet to see any patient hardly which has having a high HDL level. Very rarely seen the patient with, and most commonly we see the patient if we do get our cholesterol done, we must have most of them having a HDL level below the optimal level. So this is a more common in our population, and is in an older and as well as in a younger population. So the major cause is a plaque rupture, whether this is a occlusive plaque or non-occlusive plaque, which is only having the vessel walls and causing the positive remodeling, and that get ruptures and can cause the MI in this group also. Similarly, the recreational drugs used by psychological factors to obtain a good drug history should be paramount in younger age group. It is not. It isn't seen that if somebody has used the drug in last 24, 48 hours or even in a few days, that can cause also as vessel spasm and increase sympathetic drive. That can also cause increase the thrombogenicity inside the vessels and rupturing of the minor plaques. They all various mechanisms, they come into actions and they can cause MI in younger age group. Marijuana use was also associated with almost 5 times higher risk of MI over baseline, especially within the first hour of use, and role of psychological stress poorly recognized and underappreciated, and higher prevalence of depression, anxiety, and hostility in younger patients like contributes not only to addiction but to the pathogenesis of acute and chronic cardiovascular disease. Similarly, MI due to spontaneous coronary artery dissection, myocarditis, and coronary embolisms, they are also seen in this younger age group. And basically, coronary artery dissection occurred by intimal disruptions or intramural hematoma is not due to the underlying atherosclerosis, iatrogenic cause, or trauma. We usually see at some time interventionists, they also come across this kind of patients that we are putting the stent and then the lesion is transferring beyond that stent, and then you have to put another stent. It was basically intramural hematoma, which are progressing as we put the stent and causing the obstruction of the vessels. So spontaneous dissection, intramural hematoma, we see in our practice while using doing the primary PCIs in young patients also. It is more common in young females, especially as pregnant women come with anterior wall MI or some ischemic heart disease changes. Then we should suspect the spontaneous coronary artery dissections or intramural hematoma in these settings also. And recent series suggest that up to 1 to 4% of all causes presented with acute coronary syndrome may be caused by spontaneous coronary artery dissection or occur in younger women. And this also an important etiology in MI related to pregnancy also. And prevalence of myocarditis varies, but recent meta-analysis reports in 33% of the patients with MI in non-obstructive coronary artery disease, we come across with the myocarditis, especially in COVID area. We are noticing more and more cases they are reporting that coronaries are normal, but patient presented with typical ECG changes in inferior, posterior, anterior wall MI, and then we definitely there is regional wall motion abnormality. When you took them to the cath lab and you see the normal coronaries artery are minor diseases, and this can occur due to the myocarditis or due to the viral infections also. The prevalence of myocarditis varies from 2 to 48% in autopsy series and 9 to 16% by endomyocardial biopsies in adult and non-ischemic. Coronary embolism considered a cause in MI in 4 to 13% of the cases in this age group also. We should suspect coronary embolism if patient is having already exposed to some hypercoagulable state, nephrotic syndromes, or stasis anywhere in the body, which can initiate the thrombosis or stasis inside the heart, like atrial fibrillation, and then that can be transferred to the left side of the heart through patent foramen veil and can go into the coronaries. And we, in our part of the world, we also have a lot of patients with rheumatic heart disease with atrial fibrillation, and sometimes in younger patients we see the cases of thromboembolism from left heart, atrial fibrillation, mitral stenosis patients. They present with the acute coronary syndrome or with the ST elevation MI and memory urgency, and we can see that this coronaries are normal, but thrombus is from left atrium or somewhere else is shifted due to atrial fibrillation or due to rheumatic heart disease into the coronaries also. This can be a cause in younger age group of astronomical characterization of ruptured plaque is now feasible with the OCTs and intravascular. As we are imaging more and more patients are becoming, we are seeing that positive remodeling is a major cause in these patients. A minor plaque that gets ruptured, but that plaque grows inside the vessel wall. They are not obstructing the lumen of the vessels, and on angiographically we see that this is a normal lumen, but basically the heavy burden of plaque can be seen on OCT or IVUS studies. So classical demographic profile of such patients include younger women who are smoker but do not have other cardiovascular risk factors such as diabetes mellitus or hyperlipidemia, commonly seen in patients with plaque ruptures. So coronary vasospasm, the last thing which we can discuss, that coronary vasospasm can occur in normal coronaries and is higher in Asian population. Is used if we see underwent coronary angiogram patients, the coronary spasm was induced with gonorrhea, 20% who had recent MI, and in 15% who had chest pain. So the patient with acute coronary syndrome, among in one study, the patient with acute coronary syndrome had no demonstrable coronary artery disease, but still coronary artery spasm can be seen with the provocative test is applied. So these are the few important causes which we have to consider while considering or treating a patient with acute MI presenting in younger age of group. We should not forget that our lifestyle is changing, and the atherosclerotic plaque, they are more aggressive in our populations, and dyslipidemia is more aggressive in our populations, and atherosclerotic plaque is growing earlier in our population, but still we have to consider all other causes also in our population. Thank you very much.
So kind of you. Thank you, Tariq Abbas. Now, could you kindly stop sharing the slide? You have to stop sharing. Thank you. Extremely, and hats off to you for going through this whole presentation in exactly 15 minutes, under 15 minutes, about 14 minutes. And it is really nice of you to have been able to push it up. You know, when we were initially thinking about the people who must be involved in such programs, the idea was that you should have people who have the ability to reach out. Those who have the gift and the knack to reach out and get people on board. Mostly the cardiologists are not that friendly people, and they can't get out and reach people out. But Dr. Fawad, our young cardiologist from NICVD, has proved us all wrong. And he, mashallah, has now got a fan crossing of nearly 500,000 people who look into him and try to get. So when we were deciding who must be the speakers, we wanted people who have a fan following so that the messages then can go across. Fawad has been a most eloquent presenter, and his real beauty is actually to see him talk. And then he starts mesmerizing you, and at times, beautiful young man who has got talents which normally most of us do not carry. So without further ado, I would let Fawad come up and ask him to start sharing his slides and do his magic and explain what is happening with the young and the beautiful. Fawad, starting the watch. Over to you, Fawad.
Inshallah. First, I'm really thanking you for such a nice introduction. Since this is a subject which is not very, you can say, extensive, so you may found repetition during the presentation. Whatever Tariq said in between, few of my slides will be overlapping, but what I do, I'll just cover the subject. MI in young patients, as Professor Bilal Mohydin was saying that he saw, we literally saw daily patients in teens with either ST elevation. We have to look for spectrum of disease. You can have stable silent ischemia. There are multiple ways, acute coronary syndrome. And behind that, all this is this atherosclerosis and atherothrombosis. Plaque formation and then rupture of that plaque leading to the event. Today, we are talking about this event, that how it happens in young patients, how is it different, or whether it is really different from older population or not, and what we have to look for when we are dealing with young patients. So basically, the disease process divided in two phases: atherosclerosis, initiation and progression of plaque, and atherothrombosis, where you have a rupture of plaque which leads to event. Now, when we talk about risk factors in young patients, as Tariq told, there are multiple other reasons, but it's almost conventional most of the time. So it's not the way that किसी जवान आदमी को अगर MI हो रहा है तो इसका मतलब है उसके पास बाकी risk factors का issue नहीं है, हम protein CS ये सब ढूंढने लग जाएं. We'll show you the studies how frequently we see the conventional pattern of atherosclerosis and rupture plaque. So we have to work on these conventional risk factors, starting from smoking, physical inactivity. And these two are the culprit in young I have seen. There's no physical activity, diet issues, and smoking. These three is the constellation really taking a major part as a risk factor for CAD. And then with that obesity due to physical inactivity and like diet, indisciplined diet leads you to that impaired sugar and that constellation of metabolic syndrome. And you see most of our young population after crossing 25 and 30, you hardly found a real person who's doing his physical activity, whose diet is adequate, who's having no obesity, is not smoking. You found, especially whether it's male or female, both. So that's conventional factors are very important. As you see there, I'm just not giving you the references, but these all taken from different study. Etiology of atherosclerosis CHD is limited to conventional risk factor as an individual, some other difference. Prevalence of smoking, another study found smoking to be higher in young patients. Family history of CAD is also important. If you have a premature family history of CAD, you should be more cautious. Lipid abnormalities, as you tell, triglyceride and HDL, hyperhomocystinemia, lipoprotein A, anger, psychosocial stress, they are not that dominant. Major risk factors are the conventional one. But once you're not finding these conventional risk factors in your patient, then you have to look for these novel risk factors as well, or a rare risk factor as well. You sometimes may found them as well in your young patients. But ideally, it's the conventional one. Here is a review recently, 2020 acute myocardial infarction in young adults. And here you see the reasons behind plaque-based mechanism dominant as the etiology of myocardial infarction. If we see after angiographic evidences, 2/3 of the patients have plaque rupture as the conventional. And we do see that same happenings. We're doing almost 20, 25, sometimes even more than 30 PCIs daily. And in young patient, you see the same plaque which is rupturing. Certainly you have to look for other as well, which is another entity, which is IFC. IFC is just, you can say, an intact fibrous cap with slight erosion. So you may found some clot there, but hardly found any recanalized vessel and rupture. Certainly, ideally you need IVUS to look for. There may be a plaque behind in the beneath that thrombus formation, but it's just an erosion, not a classical plaque. And these vessels are usually recanalized. And lastly, these rare mechanisms, which are other one, are very, very, you can say, a minute percentage, which is spasms, hypercoagulable state, thromboembolism, myocarditis, and drug use. It's not that common. And this is the review of recent 2020. We usually see young patients and think of these rarer causes as first. No, you'll find the conventional atheromatous plaque there, with certainly more of a clot burden as compared to the plaque itself, difference than the conventional one. Worsening angina culminating in MI is rare in younger patients. You'll find acute event right from the beginning, some amount of angina, so have to be very cautious in these patients in a way in picking the disease. You may not find classical ST elevation initially. These patients start with stuttering symptoms, which sometimes people may be taking non-conventional and non-specific, and certainly within hours or within 24 hours, they may develop classical MI. So worsening angina behind that acute ischemic event may not be there. That's very important to consider when you're dealing with young patient. As Dr. Bilal mentioned, one of his, even doctor had this symptom and he did the cath and found to have an occluded LAD. First onset of angina that rapidly progressive to fully evolved MI is often the case in patient with less than 40. That's very important to understand. A thing that symptom and MI. So you have to have a very low threshold in picking them because they don't have that collaterals, and the first MI may be life-threatening. Then prevalence of stable angina in young adults reported 24% in one study in series of patients who had MI less than 45 years of age. 69% denied any chest pain before that MI. That's very important to consider. No background. This patient may be playing football one day before, and this day is developing symptom. If you're taking lightly, you may miss him with that acute, severe, life-threatening event. That's very important for the audience to consider when you're dealing a young patient. 2/3 patient, non-ST elevation MI, chest pain characteristics similar to that of old age. These are taken from various studies. I'm not giving the references, but these are all evidence-based. Women have 5 times higher odds of having myocardial infarction with non-obstructive. Look for drug use, cocaine, or source of thromboembolism. Suspect myocarditis in patient with history of viral illness who's presented with worsening heart failure. These are additional things which I'll give you an algorithm at the end deciding about the pathophysiology behind the event. Male and female patients, acute AMI prevalence is lower in young women as compared to age and race, gender. It's lower in young. But once it's happening in young female, it's seen that most of the time that have pre-health status, more comorbidity, higher in hospital, or longer-term mortality as compared to young male. That's important to understand. Most of the time, these young female, either having diabetes or any other major risk factors, their hospital stay is more complicated as compared to young males. This is something according to the data. As you see, that's a comparison. Prevalence, smoking, hyperlipidemia. In comparison to male, female, hypertension and diabetes, more in females, family history, hyperlipidemia, smoking, more in males, worse health, females, more comorbidity, females, depression and depressive symptoms, male, coronary artery spasm, male. So this is just a comparison as compared to ages. Regarding angiographic finding, that is again important when you are dealing with these young patients. Recanalized or more thrombotic than atherosclerotic element in occlusion. And that's why when you dealing with such kind of patient, their lesions, although looking 99%, but a number of times this 99% lesion after acute MI may be 70-80% of clot or even 60% of clot. You aspirated, you found something, just an erosion there or a very 20-30% of plaque. So be careful dealing such lesions, no predilatation, taking care of that high burden of clot according to individual cases, although aspiration is not that much advocated nowadays, but we in our population in young patient have seen that we have to aspirate a number of times. And if you don't, you found that really difficult kind of situation dealing a no reflow or slow flow phenomena. That's very important in young patient to understand more thrombotic as compared to atherosclerotic plaque. Single vessel disease is more common, but it's not the rule. A number of times you may found 3VD and extensive diseases because again, the background is that they have that conventional risk factor leading to atherosclerosis. This is the algorithm I would like to share. This is the Virgo, very common study done 2-3 years back, which has given you an algorithm how to approach towards a young patient with MI. Here you see that Virgo classification, which is an angiographic evidence of plaque-mediated culprit lesion. Once you do angiography, and if you're found there angiographic, a number of time, almost 80-90% of the time, you do pick that yes, there is some lesion with some plaque in it, with some clot in it. So in those patients, 2,425, they found to have this, and they are classified as plaque-mediated culprit lesion. So even in young patient, majority have the conventional plaque and rupture on top of that. After, in this algorithm, if you see that is no, that your angiographic evidence of plaque-mediated culprit lesion is not there, then what are the possibilities? That other defined mechanism, no or yes, and other defined mechanism, what are there? These are scud, spasms, emboli. So there is no plaque rupture as such. And these patients were very low. You can see just 31 patients have that kind of situation where you don't found the atherosclerotic rupture plaque. And this third group was the uncertain, where you are unable to make out what's going on. That is just 11 patients. So 366 were that other defined mechanisms. And even that in other defined mechanisms, have you found any obstructive CAD there? Yes. More than 50% or less than 55% further division. Since I'm running short of time, that's why I'm just quickly going through it. It will be displayed there. You can see furtherly. Purpose of showing this algorithm, which is a very busy one, to show you that it's all the conventional one. It's not the rare thing you think of in a young patient. It's atherosclerosis, rupture plaque, which is causing the problem. So we have to look for even these conventional risk factors in our young patients to be taken care early. Even in their teenagers, we have to re-inculcate lifestyle modification, exercise, diet, smoking cessation, looking for the risk of lipid, diabetes, hypertension, and taking care of them very early to prevent this pandemic, which is really escalating day by day, a young MIs. With that, I thank you, Professor Bilal. He's, I think, now be satisfied with that.
Thank you.
Although I do get out for 1 to 2 minutes, but I'll try to keep it within 15 minutes.
You got it right. I was looking at the watch. You got stuck. That's why. Now you need to unshare yourself, and then we will proceed to our final speaker. Please kindly and share yourself. Now, fantastic presentation, a lot of issues discussed, a lot of things pointed out. Inshallah, as we proceed after the last talk, then we'll have a better idea. Dr. Amber, now mashallah, Professor Amber, comes from Peshawar and looks after all of our friends of that area, and she has got a wide experience because of her, like Abid Amin Saab, they look after the neighboring countries because just local doctors like us in Lahore, they're also international doctors because they have to provide medical aid to a lot of communities over there. Amber has really done a fantastic job of building up her department into something that we all desire of. And hats off to her. When we were discussing again the team that needs to discuss this whole issue, we needed to have a young lady over here. And who better than Amber, because she has really put in a lot of effort and is further doing more work for the community at large over there. So without further ado, may I request Professor Amber Ashraf to kindly come in and give a presentation. Please.
Thank you very much. So today I'm going to talk on post-MI-Precautionary measures and lifestyle modification in young population. And as the topic we all know is very pertinent, so ये वो subset of population है जो day by day हमारी community में due to so many comorbid condition की वजह से इसके numbers ज़्यादा हो रहे हैं. जैसे अभी बिलाल साहब ने कहा, in the last few months he saw so many young patients with acute myocardial infarction. The same is the case in all the teaching care hospitals and the facility, and it's very alarming. And so we must have to find out how we are going to look after the comorbids. And what is important? The important is prevention is better than cure. And that's why today we are going quickly touch these important points. As we know, the primary prevention is no doubt is the need of the time. And we must have to develop a preventive units in all our teaching institutions and the rest of the cardiology departments, because as well as the secondary prevention is important in post-MI patients, the primary prevention is also very important. And according to the recent guidelines of ACC and ESC, etc., we are working on it, and that's very important. So, as we know, cardiovascular disease, the #1 cause of death worldwide. Here, I just want to devise this formula or these 5 key topics and steps which we are practicing in our department, and especially in young post-MI patients. And I think so, if we start developing or working on these points, it will help the young doctors to educate their patients and to look after for the secondary preventive measures in post-MI young patients. One is the cardiac rehabilitation and ongoing care, then is the lifestyle modification, and the goal of the intervention should be identified well in time so that we can match these goals during our follow-up visits. The therapeutic intervention and very important component, that is an integrated communication. So basically, this is a design which is being practiced in different countries. And here we want to encourage the two-way dialogue between the patient and healthcare professionals. ये time जब तक हम मरीज को नहीं देंगे और उसके साथ discuss नहीं करेंगे उसकी disease, उसके मुतालिक तमाम चीजें, it's very difficult. We can achieve our goal. We must have our own guidelines so that we can practice those guidelines in our own community. Then raise the standards of the care and maximize healthcare resource utilization. That is also very important in order to improve the outcomes in post-MI patients, especially the young patients, which are really in their bread and butter earning phase और जो के backbone हैं अपनी families के, इसलिए हमने prevention पे बहुत focus होके काम करना है. That's why the optimal care after a heart attack is a guide for me, for you, for your patients, and 5 steps for this optimization is the cardiac rehab. We all, as we know and we are practicing, the vital to help the post-MI patient improve risk factors for cardiovascular disease. It provides a link in post-MI care between the primary and secondary care. वो जो young patient हमारे पास आता है, जहाँ पे हम उसे secondary care के लिए करते हैं, हम उसकी family में बाकी लोगों को भी workout करें और जहाँ ज़रूरी है वहाँ पे primary prevention पे काम start कर दें, so in order to reduce the disease burden in upcoming generations and the rest of the family member. Here, very important thing is each post-MI patient should have an individualized plan, which should be developed in the hospital before a discharge. और ये तमाम चीजें जो हैं आगे लाइफ में और cardiac rehab में बहुत फायदा देती हैं. Each cardiac rehab plan should enable the patients to understand and take responsibility for their recovery and continue health. जब तक उस मरीज को हम मोटिवेट नहीं करेंगे, वो कुछ टाइम दवाई लेता है, छोड़ देता है, दोबारा हमारे पास आता है. Each one of us are facing all these problems day in and day out. So we introduce the concept of risk and importance of cardiovascular risk factors. Dr. Fawad ने बहुत अच्छी तरह already highlight किया है, and we must address the specific area concerning patients and their partners. यहाँ पे families बहुत important हैं और उसके लिए हमें क्या करना है, lifestyle modification करनी है. अभी सब कहेंगे कि ये पिछले 4 महीने में कोरोना है, COVID-19 में सब लोग घर में बंद बैठे हुए हैं, तो हम कैसे अपनी lifestyle modify करें. But still it is very important. We must develop something exercise, healthy foods, and the family members, especially those patients who have a post-MI era, they should be motivated, so have to adopt a positive, healthy lifestyle and changes together. As we all know, the healthy food, the balanced diet, fresh fruits, vegetables, less fats, and try to have unsaturated fats, sunflower oils, and olive oils. These are the things which on each visit should be inculcated by the preventive department, and proper dietitian should be there so that they calculate a balanced diet program for these patients and motivated them to eat nuts, whole grain rice, 5 portions of fruits and vegetables, reduce the salt intake, which should be less than 6 grams per day, and encourage the yogurt and milk and all the healthy foods too. So increased physical activity is very important thing. For that, we must have to educate them and tell them 30 minutes of moderate exercise each day is important. और इन्हें हमें बताना है कि वो लोग फिजिकली इनएक्टिव है, उनके नुकसान क्या है. वो ऐसा है कि जैसे वो बैठ के स्मोक कर रहे हैं. सो जहाँ पे हमने क्विट स्मोकिंग का मैसेजेस उनको देने हैं, मोटिवेट करना है. और ये हाई टाइम है पोस्ट MI जब हम अपने मरीजों को क्विट स्मोकिंग के लिए मोटिवेट करते हैं, उसका एंड रिजल्ट बहुत अच्छा है. वी हैव कंडक्टेड studies on it and the outcome is really very good. This is a high time. We must have to tell them, educate them how to quit smoking, as well as to manage their weight according to their height, according to BMI, and this will help them to control their disease. Although the alcohol is not so common, but still those who are taking, we must have to educate them and tell them how to look after their alcohol intake. So number 3 is the goal of intervention. That is very important. हम जो करने जा रहे हैं, हम achieve क्या करना चाहते हैं. The goal of intervention is to achieve optimal control of all modifiable cardiovascular risk factors. ये जो 5 हमारे दुश्मन हैं, इनको आइडेंटिफाई करें, मरीजों को, उनकी फैमिलीज को हाईलाइट करें और बताएं अगर इसे हमने अच्छे तरीके से कंट्रोल कर लिया और ये इसके टारगेट्स हैं, ब्लड प्रेशर इतना होना चाहिए, कोलेस्ट्रॉल इतना होना चाहिए और किस तरीके से आपने ये अचीव करना है. और इसके साथ साथ द क्लिनिकल एविडेंस कंसोलिडेटेड फॉर कंसाइज एंड डेफिनेट गाइडेंस ऑन ऑप्टिमल टारगेट्स. एंड दैट इज इन दिस वे we must have to ask our patient to come regularly and motivate their family members and help them in order to achieve their goals regarding their blood sugars, the BMIs, and waist hip ratio. That's very important. The next important thing is therapeutic intervention. जहाँ पे हम बात कर रहे हैं प्रिवेंशन की, प्रिकॉशन की, वहां पे मरीजों के साथ प्रॉब्लम क्या हो रहा है? प्रॉब्लम ये हो रहा है कि वो दवाई लेते हैं एक महीने के लिए और उसके बाद आहिस्ता आहिस्ता उसके नंबर्स कम कर देते हैं। यहाँ पे थेरेप्यूटिक इंटरवेंशन बहुत जरूरी है कि हम बताएं कि आपको ये 3-4 किस्म की दवाई रेगुलर लेनी है, लाइक लिपिड लोअरिंग थेरेपीज है, बीटा ब्लॉकर्स है, एसी इनहिबिटर एंड वेयर इट इज इंडिकेटेड द डाययूरेटिक्स. So we must have to sit with them, discuss with them, and tell them why these medications are important, because poor drug compliance is a very important factor in reinfarction or uncontrol of their comorbid conditions, which leads to further complications in post-MI, especially in young patients. We have to motivate them. Regarding the lipid lowering drugs, then the therapeutic intervention where AC inhibitors, ARBs are indicated, tell them how to take it, how to look after, and pre-testing and monitoring of their renal function and electrolytes is very important, which must be done regularly according to the set protocols. Then anti-platelet agent, and especially in those young patients where we are doing the primary CIs, we are putting stents. That is something we must have to educate them properly with good 15-20 minute sessions and ask them to reflect back on it, because most of the time क्या होता है, आप ट्रीट कर देते हैं, स्टेंट पास कर देते हैं. अभी ये 3 हफ्ते पहले एक पेशेंट मेरे पास आया, यंग पेशेंट, इसी तरह एक्यूट एमआई में. उसने बड़े आराम से किसी जीपी के कहने पे अपनी clopidogrel stop की हुई थी, and he was again symptomatic and things like this. So that is very important. We must tell them to continue this drug, and without cardiologist opinion, please don't stop that. Another important drug, and we must have to tell them how to mention wherever there is a contraindications to aspirin and clopidogrel, that is the one thing we can use it. And aldosterone, as we all know, patients post-MI who develop an heart failure, there it is very important to explain them how to take and what will be its benefit when we are regularly using these medications. And they should monitor their urea creatinines and things in order to have a very healthy life and well-controlled blood pressures, as well as diabetes, as well as the other comorbid conditions. The fifth very important component in precautionary measures post-MI is good communication between secondary and primary care, community services, and patient is very essential. I think so that is the area where we all should have to work so that we can have a better outcome, and post-MI hospital discharge summary is a vital component of a successful communication. ये वो पॉइंट है जहाँ पे मैं समझ रही थी, जैसे अभी बिलाल साहब ने कहा, अपने डिपार्टमेंट को डेवलप करते हुए ये वो प्रॉब्लम्स हैं जो आप फेस कर रहे हैं. एज अ कार्डियोलॉजिस्ट, एज अ टीम, वी पुट अ लॉट ऑफ एफर्ट even doing the primary PCIs, treating these young patients. लेकिन जब वो discharge slips हमारी बनती हैं और उसमें discharge summary up to mark नहीं है, that's creating a lot of problems, and all the effort which we have done as a team वो wash out हो जाती है. So confirm the diagnosis, provide results of the investigations which are already performed, or फ्यूचर में प्लान क्या है वो मरीज को, पेशेंट को बहुत अच्छे तरीके से समझा देना चाहिए. एंड प्रॉपर डॉक्यूमेंटेशंस ऑफ द इन हॉस्पिटल कॉम्प्लिकेशंस एंड द इंटरवेंशंस व्हिच वी हैव परफॉर्म ड्यूरिंग दैट स्टे शुड बी डॉक्यूमेंटेड. डिफरेंट हॉस्पिटल्स के अपने डिफरेंट सेटअप चीजें हैं, बट दीज आर वेरी इंपॉर्टेंट कंपोनेंट्स एंड वी शुड वर्क ऑन दीज. यहाँ पे हमारे कल्चरल सेंसिटिव सेट पॉलिसी एंड डॉक्यूमेंट बनाएं जिसपे ये तमाम चीजें रिकमेंडेशंस हो, और डिस्चार्ज समरीज मस्ट बी साइंड बाय अ प्रॉपर रजिस्ट्रार्स एंड सीनियर रजिस्ट्रार्स सो दैट वी हैव अ बेटर आउटकम. सो have a healthy heart. For that, we must control our cholesterol and avoid the unhealthy fats, control our blood pressures and diabetes, stop smoking and limit the alcohol, managing weight, as well as do a daily exercise, which is mandatory, at least 30 minutes per day, consume fruits, vegetables, and reduce salt intake, and 7 to 8 hours of sleep is a very healthy thing. But as a cardiologist, 24/7 on call, it's very difficult. So we must have to think about that. If you want, I go quickly on this post-MI care case history. There is a person who is supposed 46-year-old male who is smoker, He's the driver, hospitalized yesterday with MI, no previous history of myocardial infarction, BMI 34 kg per meter square, and he has his wife and a teenage son. What would you recommend for Mr. ABC in terms of cardiac rehab and lifestyle modification? फेसबुक पे जैसे मुझे वहीद साहब ने कहा कि इंटरैक्टिव वो चीजें हैं, these are the questions for the trainees who are looking after these presentations, और वो सुनेंगे तो प्लीज इन क्वेश्चंस के आंसर्स वो खुद दें, that is very important. And what would you want to see include in hospital discharge summaries? So these are very important pertinent points regarding the preventive side of post-MI young patients. So in cardiac rehab, as we have discussed, the individualized plan for each patient should be discussed with the senior. It should be documented in a proper 1, 2, 3, 4 manners, and the patient should
Dr. Amber, sorry, Dr. Amber, you have shot up your time. Please wind up quickly now.
I'm just covering it. It's just the last slides, and it provides them how to look after their cardiovascular risk factors and how to visit that. And these are the risk factor management plans in which they are going to control themselves, the healthy diets, the lifestyle modifications, and the discharge slip. In this way, they are going to look after this. So we all should make a promise for our own heart, your heart, and healthy hearts. A promise to our families to cook and eat more healthy food, to promise to our children to exercise more and help them to be more active, to say no to smoking and help our loved one to stop it. A promise as a healthcare professional to help patients give up smoking and lower their cholesterol. A promise as a policy maker to support policies and promote a healthy heart. A promise an employee to invest in healthy heart workplaces. A simple promise for my heart, for yours heart, for all our hearts. And we must have to risk our risk factors, calculate our heart age. And important thing is, as all we are doing, we must have to motivate the government and ministries of health must accurately understand the scale of the problem by investing in cardiovascular surveillance and monitoring. That is the need of the day for the prevention. And we must have these future plans which should be inculcated, and we must have a parks, healthy activity life. But in this COVID era, we must develop something which we must do it while we are doing indoor activities. Thank you, Dr. Bilal, for giving me extra 1 or 2 minutes. Thank you for patience.
And you have stood the test of the thing that, as I said, that one of the international speakers and one of your last slides were from African children. I wish that could have been Pakistani children also holding out the hearts. But anyway, just to make the matters on lighter side. Indeed, it is a difficult task to hit off such a topic in these small 15 minutes allocated time. But we all have got our own other commitments, and we have to sort of, rush around. And my special thanks to the president of the society, Professor Soulat Saab, the vice president of and an extremely important Abbas for joining in. This has been a pan-Pakistan effort conducted with the help of Wilson Pharmaceutical, a small effort by the Lahore chapter, and I'm sure all our other groups and chapters are also doing a lot of work. So before I open up my further discussion points, if there are any, I would first request Professor Abbas Saab and then Professor Soulat Saab to give their comments as we proceed further. Professor Abbas Saab,
my personal experience for young MIs, number one, I would like to change the definition. From South Asian studies in England that we have atherosclerosis, which is 10 years advanced. So whatever is for 45 there is 35 here, or 30 if you change it to 40. So I think our young definition should be under 30. The maximum is under 35. If you take it over that, then they are no longer younger as far as their coronaries are concerned. So that was the first thing. And typically, anecdotal experiences that they are young, obviously, by definition. They are males, vast majority. They have a single vessel disease, again, a vast majority. It's an LAD lesion. It's a proximal LAD lesion. And as one of the slides mentioned, 92% are smokers. So that, I think, is the primary variable which is almost always present, and that for the young MI is the most crucial aspect in their future as well as in their past, and why it occurred and what has to be done to prevent it in the future. There are many other reasons which have been listed. I'm not going to go over them because they are so uncommon. This is by far the commonest reason. And in the era before primary angioplasty, because streptokinase was used, the underlying atheroma was often found to be 50% or less. And it was always a struggle whether you should do anything for him, for this person, the young person who has come in, or just leave him on conservative management, because there was nothing really to stent there by standards of 70%. So I think what I would really like to see is our own data. We are presenting again data from abroad. This is not South Asian data at all. It's not even South Asians in England. We need a registry. There are only about less than 5% of such cases under the 30 or 35-year mark. And if I was counting on my fingers, 10 centers collaborate in Pakistan, in 1 year, we can get more than 1,000 such cases, easy, and have very good data, which is really worthwhile for us and for presentation outside also, because this comes up frequently. What is your data? And unfortunately, every time we are at a loss to say what is our data. I wish, as a part of this continuation of this symposium, if we already have 3 centers on board here, in fact 4, if you count Bilal also, and we have others which can be asked to contribute. And if we make a registry of just these patients, and I think we will reconfirm what I've already said, but even that is something, at least it will be bound, not anecdotal, but it will be there in the form of medical evidence. I love the talk of Dr. Amber, and especially the point about the discharge summary. I think the discharge summary tells you a lot about how the patient was managed and what is the status of the hospital or the medical place which was managing. Because unfortunately, the management has been excellent. Primary angioplasty was done successfully. Patient was saved from damage. But the discharge summary for future, which is really the guideline for the future, is very inadequate. And often I find even NGSID is not there. Sublingual nitrate is not mentioned for a patient with triple vessel disease whom you have only tackled 1 vessel. So this is something really which needs to be highlighted. She has done it very well. I think it's time we also highlight to the other centers. And it is also a way to do medical audit to see, are we prescribing the right medicines in the right dosages to our patients? Again, this is something which I think Bilal will fully agree. We are underdosing our patients majority of the time, especially regarding statins, which are regarded as the most important drug in the post-MI phase. So I think these are some things which I would like to point out, and I would again stress rather, that we must have a registry.
Dr. Zalil, really for appreciating it, and I think so it make a lot of difference. But unfortunately, आप सब भी माशाल्लाह पहले करते रहे, हम भी कर रहे हैं, लेकिन जितनी एनर्जीज इस चीज में पुट करने पे लग रही हैं, और somehow आप जो न्यू ट्रेनीज हैं, न्यू डॉक्टर्स हैं, आप बहुत मुश्किल से उनको मोटिवेट कर पा रहे हैं कि आपने जो कुछ किया है उसको डॉक्यूमेंट करें. दैट इज द प्रॉब्लम व्हिच आई एम फेसिंग इन माय डिपार्टमेंट. आई डोंट नो हाउ द रेस्ट ऑफ द पीपल आर टैकलिंग, कभी प्यार से, कभी समझा के, कभी बहुत तरीकों से, बट स्टिल क्लिनिकल ऑडिट इज वेरी इंपॉर्टेंट और हमें करना चाहिए, देखना चाहिए इस चीज को, लेकिन वो टारगेट हम अचीव स्टिल नहीं कर सकते जो दिल चाहता है अचीव करने को. थैंक यू वेरी मच.
Thank you. May I request Professor Abbas to once again try and come back on? Hopefully we can listen to his comments now. Any comments, especially now from Fawad? Fawad, would you like to give a comment till we try and get him in?
Yes, I think primary is the prevention. Picking the high-risk patients, advocating educations for multiple means. That's very educate and bring them to the positivity of life once they are healthy. Once they had an MI, then you are left with nothing. It's important prior to that. And I personally think even from the childhood, this positivity should be inculcated in the society, how to really come to a healthy lifestyle in terms of diet, exercise, physical activity. And I personally think that role of social media is really very important in now this day and age. I don't know why a number of people like you are not really into that, because we see so much things on social media and there is a thirst there to accept, to really listen to these things and even transform their life. I see a lot of pictures of my followers, their comments in my inbox that just for sake of your description about obesity and your diabetes, and we have taken care of our all things, and that, so that's very important. Education, education, education. That's very important.
I would agree with Fawad.
Hello? Hello?
Yes.
Can you listen?
Yes, please.
Okay,
you're on. We are eagerly waiting to listen.
Oh, okay. Bilal, thank you very much. I'm grateful to Wilson Pharma for arranging this webinar, and particularly to you that you have put up my name to be in the panelists. Thank you very much. Bilal, what I have seen is that when I was doing my training in Karachi at an ICVD, and these young people who used to come with acute myocardial infarction, most of them used to be blue-collar workers. That is very important. And my teacher over there at that time, like Professor Abdul Samad and Professor Azhar Farooqi, they used to say, क्या आप इनसे पूछें कि ये लोग दोपहर को जब काम करते हैं पकोड़े और समोसे खाते हैं या नहीं, और जब उनसे पूछते थे तो definitely they used to take these samosa and pakode, which is used to be fried in and in the oil, which is usually reused so many times. So because you know these blue collar workers at younger age, when they get acute myocardial infarction, so it has a lot of impact on the social status, psychological status, and even the economic status of the country. That is very important, because even in those days, 25 years before, when you used to do training at an ICVD, we used to get very young population with acute myocardial infarction. And another important factor in acute myocardial infarction is usually genetics. Here in Quetta, I know few families who they are my patient. Every member of the family, they had a coronary artery disease evident before the age of 45. And most of these patients, whether they did their angioplasty or they went through the cabbage. So this is no doubt a very important part of cardiovascular disease in young population. And you know, other factors like drug abuse, that is very important. There are few Indian and Bangladeshi studies where a very young population with drug abuse usually get acute myocardial in very younger age. And the other risk factors like conventional risk factor, diabetes, smoking, hypertension, hypercholesterolemia, it is usually there. We conducted one of the study at NICVD at that time when I was doing my training with Professor Abdul Samad, and around 20% of the population who got acute myocardial infarction and went through coronary angiography, they were young, that is less than 45 years, as comparing to the Western population, which is around 6% over there. So this is very important topic. We have to go through this, and what are the other risk factors apart from the conventional, that is very important. Dr. Tariq Abbas, he has very much explained the risk factors in the younger population. I will not go through that. And then the Dr. Fawad, when he presented his presentation as the atherothrombotic phenomena, which leads to acute myocardial infarction in younger population, and even in a minimal intimal disease, and the patient get myocardial infarction and rupture of the plaque. And again, Dr. Amber Ashraf, she presented a very important part of the today's webinar, that is how to rehabilitate these patients after acute myocardial infarction, and particularly that lifestyle modification and that the rehabilitation center. Thank you, Bilal.
Thank you, sir. Just to add on to your point further, and to Fawad and Amber and Tariq's point, when we talk about this lifestyle modification, one of the standard teachings for post-MI we always recommend is that you must do at least 30 minutes of walk at least 5 times a week. So that means 150 minutes are there. Now, if you sort of translate this into your primary prevention, so this is your bare minimum that everyone should be doing. Now, when we talk about the fact that we have got our children's education to be done, and Fawad, for one, who is a great fan of the social media, and I am on the other side, my only problem is that people spend too much time now on social media and they do not do any exercise. So what actually, Fawad, you are required from your social media point is to reach out to people and tell them that at least minimum is 30 minutes, even for primary prevention, probably preferably even 60 minutes every day, walk, run, burn your calories, at least 200, 300 calories, if that can be explained in a simple layman language. And from a community point of view, the way I feel it is, from a community point of view, we all carry some social pressures. So what is required from my social pressure side is that look at all your schools at the moment. Look at these fancy, nice schools that have come up, and you will be surprised to see that most of them, if not all of them, do not have any proper playing field program over there. And it is this which is actually destroying our current generation, because they are all coming up with bellies and they're all coming up with fats in the wrong place. And the worst thing actually that they are developing is they do not develop the comradeship, the ability to work together. And that is why we have all of these things coming. Next month, inshallah, Pakistan cricket team will be playing over there, and you will see the difference of our players and the other side. Why this is the difference? The difference is that those children start playing as a child and they can learn how to dive. Our players are always afraid to dive, especially for KPK. KPK, if I remember right, they have got 4 or 5 players in the Pakistan cricket team at the moment. And the players, they come from the areas where they don't even have those grounds. And these players are fantastic players, but because they cannot learn this art of diving and the art of doing exercise as a young, thus they start losing out. Similarly, what kind of a diet a person must follow, these are the things that we need to reach out. Fawad's responsibility and all of our responsibility from a social aspect is that we need to reach to our patients. Dr. Tariq Abbas, if you're still over here, would you like to add something into the discussion? Tariq Abbas, is he here?
I, Dr. Bilal, just interrupt here. I do have done a lot of physical training events as well and shared it on Facebook as well. You may see in the morning.
That for sure.
And secondly, I am taking promise from all of you to be on live with on my Facebook page to discuss in layman language about all these things which we are discussing among ourselves. तो ये आम आदमी की ज़बान में हम आपके साथ लाइव सेशंस और आपसे सबसे हम वादा लेके जा रहे हैं, हम once a week करते हैं लाइव सेशन फॉर कॉमन मैन. तो इंशाल्लाह सबसे की आपसे इंशाल्लाह राब्ता करूंगा और वो फिर देखेंगे कि उसमें फिर आप कहां तक पहुंच पाते हैं.
जहां तक ताल्लुक है कॉमन मैन का ताल्लुक है ना, इट इज अमेजिंग कि हमारा कॉमन आदमी है ना, जिसको आज वो कहते हैं ना कि मैं 1 डब्बी सिगरेट की रोज पीता हूँ, तो यार 1 डब्बी आज कम से कम 70 रुपए की है. जिसका मतलब है कम से कम 2,000 रुपए के सिगरेट रोज पीता है, महीने में पीता है, जिसका मतलब है कि 24,000 रुपए के सिगरेट वो 1 साल में पी लेता है। और इसको अगर आप 10 साल पे ट्रांसलेट करें तो ये 2.5 लाख रुपए है। और इस वक्त ही उसको आके उसने काम दिखाना है, और ये सस्ते सिगरेट वाले हैं। और ऐसे भी लोगों को आप भी जानते हैं, मैं भी जानता हूँ, जो कि गोल्ड लीफ और मॉवा, जो एक्सपेंसिव 200 रुपए वाली ब्रांड के 3 पैकेट डेली उनकी कंजम्पशन होती है, सिगरेट से सिगरेट लगता है। और वो लोग फिर आके बाद में आके परेशान होके पूछते हैं, हमें पता नहीं क्यों तकलीफ हो गई, हमें तो नहीं होनी चाहिए थी। भाई तुम क्या, तुम्हारी बीवी जो स्मोक नहीं भी करती उसको भी हो जानी है, उसको पैसे स्मोकिंग ही तुम इतनी करा रहे हो। बट एनीवे, ये सारी बातें आपकी बिल्कुल सही है। And rather than taking too much of the time of Professor Soulat Saab and Professor Abbas, because I know they are totally committed in other activities, and also Fawad, you and Tariq, Abbas and Professor Amber, I would request that if Professor Soulat Saab permits, we will bring this session to an end, and and then we can take the final comments. And thank you to Wilson. Professor Soulat Saab, do you and Abbas Saab, do you permit?
I think so, and one more time, we should stick to the time. Despite your best effort.
I think we should be able to do something at least. And may I request our friend from Wilson to kindly take up, and thank you for your kind support for this. And inshallah, we will now, with Allah Ta'ala's blessings and kindness, meet together properly and do further work. Till that time, web is end, and over to you.
Thank you very much. Thank you very much, everybody, for this nice, informative session. I think time is also constrained, so should we put some questions, or should we bypass this?
We can take 2 questions at the most, because it's already 4:30.
Okay, fine. There is one question. What are the reasons of higher prevalence of MI in women?
Amber, would you like to take on this question? Higher prevalence. Do you agree with the first part, that there is a higher prevalence?
Okay, thank you. Important thing is we don't have our own exact data. That's why we can't comment on this thing, whether this is a true statement or not. Regarding the higher prevalence in women, that is age dependent. If we categorize that into a different age group, like 40 to 50 and 50 to 60 and 60s onward, that is in that age group post-menopausal, yeah, the prevalence is more. That is evident, and even in our setup, that is the thing. Wherever the females, they have more diabetes, hypertension, and they have more comorbid conditions, especially the sedentary lifestyles, these factors may add on. But we must need, as Soulat Saab has highlighted, among the young patient, we must have our own registry and data so that we can comment.
The women are definitely at higher risk, but before that, I think the higher is, there is no evidence that the disease is more in the younger female. But in my practice, I remember there was a very young lady. She was just 30 years. She was pregnant and she got anterior MI. And then we gave all the conventional therapy during that time. And after, when she delivered and we did her angiography, definitely she had a obstructive coronary artery disease. I mean, that is very rare in the productive life of the women. And after the menopause, I think all of you know that after the age 55, men and women both are at equal risk if they have got a different risk factor, that conventional risk factors are there. Hello,
yes,
Amber, can you listen to me? Are you part of the Go Red for Women? Yeah, I think after the menopause.
Yes, next question, please.
Yes,
10 to 15% in Pakistan now. And as far as our ischemic heart disease patients having diabetes along with it, that is about 45 to 50%. Some of these diabetic patients are florid diabetic patients that they have to be on insulin, and there are others who are just basically have had gestational diabetes or have got stress diabetes. So there's a very strong there are, for simple language thing, there are 4 enemies that hypertension, then is the hyperlipidemia and smoking. All go hand in hand, but of course in them the leader is the diabetes. I hope that answers the question. And with that, I think the time has passed, and please do pass on these questions of the people, and we'll try and send them messages separately so that we are able to answer their questions. Thank you. And with that, I will say thank you to all of you for being with us.
Thank you very much. Thanks a lot.
Thank you very much, everybody, and have a nice evening.
Thank you very much, everybody. Thank you very much.
Thank you, Abbas. Thank you, Soulat. Thank you, all the team and the organizers.